G'day, I'm Steve Fox, and I want to welcome you in joining me for a tutorial overview of canine osteoarthritis with a focus on synovitis. In full disclosure, I share with you that I have consulted with these listed organizations and that Exubrion is sponsoring this presentation. Arthritis is a broad term that encompasses inflammatory disease processes within the synovial joint. Typically, we categorize arthritis as inflammatory or non-inflammatory. Categorization, reflecting the degree of inflammation, is useful to provide a diagnostic and therapeutic framework, appreciating that various forms share pathogenic mechanisms. Immune-mediated polyarthritis, seen more infrequently in veterinary medicine, is driven by the presence or absence of extra-articular disease and pathologic in addition to polyarthritis. Osteoarthritis is the most common form of arthritis seen in dogs, affecting about 20% of adult dogs. Whereas primary osteoarthritis is idiopathic, secondary osteoarthritis is a sequel abnormality secondary to a development disorder, joint instability, or trauma. Typically, itis, as the suffix of a word or term, suggests that it's an inflammatory process. Now, sometimes osteoarthritis may be inflammatory or it may not. However, synovitis is an inflammatory process, and there is justification to make the connection of itis to inflammation of the synovium. OA is usually classified as non-inflammatory disorder, since a leukocyte count in OA in synovial fluid is typically below the threshold that defines an inflammatory disorder, and that's around 2,000 cells per cubic millimeter. OA may be defined in pathologic terms as the aberrant repair and eventual degradation of articular cartilage in association with alterations in subchondral bone metabolism, periarticular osteophytosis, and a variable degree of synovial inflammation, in that all forms of osteoarthritis display some degree of inflammation. An inflamed synovium is considered to be indicated by palpable joint swelling. Clinical symptoms of inflammation, the presence of histological inflammation in OA synovial tissue, and early cartilage lesions at the border of the inflamed synovia are strong indicators that synovitis is a pivotal factor in the pathogenesis of osteoarthritis. The traditional view of osteoarthritis as a cartilage-only disease is obsolete. As a total joint disease, bone, cartilage, and synovium communicate by way of cell-to-cell crosstalk through the release of soluble mediators and via mechanical signals. This cycle of inflammation provides an overview for appreciation that osteoarthritis is a process rather than a disease entity. Initiating the degenerative changes associated with osteoarthritis is typically complemented with some type of instability, leading to a synovitis, the overproduction of macrophages and synovial sites with synovial hyperplasia. Macrophages therein overproduce pro-inflammatory cytokines, and the inflammatory mediators therein move into and out of cartilage and the synovial lining. This initiates and drives cartilage destruction, which leads to chronic pain and inflammation as well as disability. And the worse it gets, the worse it gets. The interarticular drawing to the right of this cycle of inflammation illustrates what the arthroscopist would see, with three characteristics of osteoarthritis: synovial hyperplasia, synovial angiogenesis, and hyaline cartilage destruction. The bottom right graphic demonstrates the key cell types and various cytokines involved within crosstalk that sustains this progressive disease process. On the left of that bottom right illustration, we see the cell types and inflammatory cytokines associated with the cartilage within the cartilage. And then moving from left to right, we see within the joint space the milieu of inflammatory cytokines and chemokines that drive this cycle of inflammation. To the far right of that illustration, we see the cell types, which are macrophages and fibroblasts, as well as the related cytokines and inflammatory mediators that feed this process of inflammation. The inflammatory mediators, cytokines, detected in osteoarthritis synovial fluid can come from three tissues that undergo histological modification in OA: cartilage, subchondral bone, and the synovia. Cytokine denotes any of a number of substances such as MMPs or matrix metalloproteinases, interleukins, TNF, and more that are secreted by certain cells of the immune system and have an effect on other cells. Some researchers consider the main difference between OA and rheumatoid arthritis synovia to simply be the amount of cytokines released. Most inflammatory cytokines are thought to diffuse into the synovial fluid and act on the cartilage matrix and cytokines from a distance. Two major cytokines involved in the pathogenesis of OA, that being interleukin-1 beta and tumor necrosing factor, are mainly produced by activated synoviocytes, mononuclear cells, and articular cartilage. Interleukin-1 beta and tumor necrosing factor can stimulate their own production in an autocrine manner. They can also stimulate chondrocytes and synovial cells to produce other cytokines. Inclusive within this milieu of pro-inflammatory mediators are also matrix metalloproteinase, which is a group of enzymes that break down proteins such as collagen, adamants, especially 4 and 5, which are members of a family of extracellular proteinase enzymes involved in the cleavage of aggrecan, which is the functional unit of cartilage. Additionally, there is aggrecanase, which is an enzyme that degrades proteoglycans, which are a major component of cartilage. Synovial macrophages are crucial intermediaries in transforming growth factor B-induced formation of osteophytes, perhaps via the secretion of bone morphogenic protein, BMPs, or via a chondrogenic signal that acts on mesenchymal stem cells, or in both ways. Clearly, there's a need for some type of microenvironmental site regulating device to retard and suppress degenerative joint disease. This illustration also depicts a cross-section, in this case a drawing, of the joint. And we see at the bottom the cartilage, which has been degraded and is releasing and accepting a variety of inflammatory mediators from the joint fluid itself. Then we see the gray or the green area in the middle of the graphic, which depicts the synovial fluid. And then in the top of the illustration, we can see the synovial lining, which typically is 1 or 2 cells thick. However, in the face of osteoarthritis, degenerative joint disease, there's a hyperplasia of this lining, and that synovial depth of cells can be as deep as 10 to 20 to 30 layers. It's also at this location that we see afferent nerves, nerve endings that are sensitized in the face of osteoarthritis to be ready and active in the transmission of nociception. The source of pain in OA is not the cartilage, which contains no pain fibers. Nociceptive fibers have been described, however, in the joint capsule, the synovia, in the menisci, bone marrow, periosteum, and subchondral bone, as well as within marrow cavities of osteophytes. In normal joints, the majority of nerve receptors don't respond to noxious stimuli. However, in OA process, the nervous system is sensitized or upregulated for a response, and that response is pain. In this graphic, we're seeing in the upper left-hand corner afferent nerve endings that are penetrating the joint capsule down to the level of the synovial intima. And then lying below the green arrow, we can see inflammatory mediators. This is this milieu of inflammatorily active cytokines and chemokines. And then as we work our way to the right-hand side of that illustration, we see cartilage, and the superficial component of which is showing to be eroding. Within the joint, inflammation results in the release of many cytokines, which we've already looked at, and other inflammatory mediators being released from the synovium and the cartilage into that joint fluid. So we have quite a milieu of floating inflammatory mediators. These mediators initiate transduction, which is the creation of electrical impulses in afferent nerve fibers. And this happens from biochemical reaction in receptors that are on the afferent nerve cells. In the conscious patient, the end result is pain. As a patient loads and unloads the joint with weight-bearing activity, synovial contents move in and out of the cartilage matrix. Herein, the cartilage acts analogous to a sponge that's immersed in a bucket of water, where the water moves in and out of the sponge as it is squeezed. With weight loading, inflammatory mediators are forced from the cartilage into the synovial fluid, where they contact synovium of the joint intimal lining. Resident synoviocytes respond, like macrophages, producing additional mediators that are released into the synovial fluid. Additional weight bearing then forces these new, as well as the resident synovial fluid-bound mediators back into the cartilage and so on. And so it is that the worse it gets, the worse it gets. An optimal treatment agent would target this process as a mode of action. Studies with the depletion of synovial macrophages have shown that TNF and interleukin-1 beta in the OA synovium are produced mainly by CD14 synovial macrophages. Thus, macrophages seem to drive the inflammatory and destructive responses of the synovial fibroblasts by way of combined effects of TNF and interleukin-1 bravo. Summarizing points from this study by Bondison et al. Is one, that synovitis is implicated in the signs and symptoms of osteoarthritis. Further, two, macrophages drive these destructive responses. It's worth noting that cytokines interleukin-1 and tumor necrosing factor alpha can be self-producing and can act synergistically. A key point from the study conclusions is that the synovial macrophage warrants prioritization in the quest to influence OA disease. Several levels of evidence actually validate the role of synovitis in osteoarthritis, and a couple of those classifications are noted here in this slide. That includes clinical observations, histologic findings, molecular responses, and herein again we see a milieu of inflammatory mediators and cytokines. Also, imaging supports the role of synovitis and osteoarthritis, as does interventional results from a variety of activities. The lineup of destructive and pathologic factors in osteoarthritis are extensive. However, the major players are arguably cyclooxygenase 2, prostaglandin E2, interleukin-1 beta, matrix metalloproteinase 13, iNOS, and TNF-alpha. These inflammatory mediators originate from both the cartilage matrix and the synovium. And having reviewed the synovia and initiated some insight into our understanding of the role played by macrophages and their pro-inflammatory cytokines, we can follow the progression of osteoarthritis and its ultimate clinical manifestation of pain. Not to be overwhelmed, but by observing the cytokine network, several different cell types coordinate their efforts as part of the immune system, including beta cells or B cells, T cells, macrophages, mast cells, neutrophils, basophils, and eosinophils. Each of these cell types has a distinct role in the immune system and communicates with other immune cells using secreted cytokines. Macrophages phagocytize foreign bodies and are antigen-presenting cells, using cytokines to stimulate specific antigen-dependent responses by B and T cells and nonspecific responses by other cell types. T cells secrete a variety of factors to coordinate and stimulate immune responses to specific antigens, such as the role of helper T cells for beta cell activation in response to antigen. The proliferation and activation of eosinophils, neutrophils, and basophils respond to cytokines as well. So we see there is a complex interplay and a considerable amount of crosstalk. Historically, osteoarthritis was considered a disease of cartilage. It is that, however, it is much more. It's a total joint disease. Perhaps the focus on cartilage and osteoarthritis comes from a concern that once hyaline cartilage is lost, it is lost forever. In the body's attempt to repair damaged hyaline cartilage, it substitutes fibrocartilage, which is inferior in both structure and function. Let's take a closer look at this hyaline or articular cartilage. Take a look at its composition, wherein we can get a better understanding where, when we lose composition or structure, we also lose function. So let's look at the illustration at the top, going from the upper left-hand corner, then to the right and down to the bottom left-hand corner and to the right. The first, in the upper left-hand corner, illustrates a cross-section of normal articular cartilage, illustrating the 4 zones that comprise cartilage. Then when we move to the right, we can see the interaction of collagen fibrils, proteoglycans, and water in normal cartilage, which provides normal articular cartilage with its resilience. We then move down to the bottom left, which shows the components of an aggrecan aggregate, the functional unit of cartilage. Glycosaminoglycans are linked to core proteins through either a oxygen O-link or a nitrogen N-link bond. This functional unit is the catabolic target for the matrix metalloproteinases, the diatomates, and the aggreganases that we see in that synovial fluid milieu of inflammatory mediators. The fourth illustration in the corner illustrates repeating disaccharide subunits of the glycosaminoglycan chondroitin sulfate. Herein we see high hyaluronic acid, keratin sulfate, and dermatan sulfate that are other glycosaminoglycans found in the articular cartilage. As we look at the bottom illustrations, the bottom left drawing shows changes associated with mild osteoarthritis, fibrillation of the articular surface with a loss of superficial chondrocytes and clustering of other chondrocytes. The bottom right drawing shows changes that are associated with severe osteoarthritis. This involves deep fissuring, which occurs, and there's a loss of cartilage matrix. Chondrocytes, which are few, are found in clusters, and thickening of the subchondral bone may also be present. As the underlying structures and their functions are compromised, fissures deepen to subchondral bone. And this fissuring ultimately progresses to a loss of full thickness cartilage and exposure of subchondral bone and hibernation of the joint surface. Although cartilage water content initially increases, with the loss of more hydrophilic proteoglycans, water is subsequently lost from the matrix, rendering it less resilient and consequently less functional. The articular surface becomes dull, and it changes from a white to a velvety gray or gray-white to yellow. We need to keep in mind that there is a strong relationship between structure and function. And so as we see the degradation of the structure of hyaline cartilage, so too we see a decrease in its function. Now, with a primer of synovitis in our rearview mirror, let's take a look at a couple of key points to be made regarding synovitis. Synovitis is inflammation and thickening of the synovia, which occurs as an initiator and a driver of osteoarthritis. Synovitis is thought to potentiate cartilage damage and breakdown, as we have just observed. Synovitis is likely a major source of the pain that's associated with early to mild stage arthritis. The illustration on the left is meant to denote the so-called pain pathway. I would call it the nociception pathway for reasons I'll share with you here. That being that when a signal is transmitted from a distance by virtue of transduction, it goes through first-order neurons. We know that as transmission. It then gets to the spinal cord where more times than not it's modified and oftentimes considerably. So we call that modulation. And then the information via nociception is carried through the second-order neuron to the brain where it's interpreted as pain via third-order neurons. And that's provided if the animal is conscious. If it's conscious and processing this nociceptive signaling, then it's interpreted as pain. However, if the animal is unconscious, it's simply the process of nociception. Now, transduction is where this all starts. And transduction is where an insult, be it mechanical or thermal or chemical, actually initiates an action potential. And then following this pathway, it ultimately is interpreted as pain in the conscious animal. Now, all steroids, NSAIDs, and Bimprants are analgesics. They're pain relievers by virtue of blocking this nociception or the transmission of pain or action potentials along this pathway. However, to date, none of these agents have been shown to actually modify the inciting disease, which is to say that they treat the symptoms but not the disease itself. What's new in the treatment of osteoarthritis is targeting the joint microenvironment, focusing on the role of the synovium. And as we look at these graphics, we go to the upper left-hand corner, and this is meant to denote a osteoarthritic elbow, and the granular type of material that we see on that elbow is meant to represent osteophytes. And also depicted here as a drawing would be both an ununited anchineal process and fragmented coronoid. And of course, what we would see arthroscopically is then that arthroscopic capture, which is labeled synovitis, and we can appreciate there the hyperplasia of the synovium and the angiogenesis with all the reddening that's in that tissue. Then we go to the graphic below those two, and we walk ourselves right back through the rear view mirror where we're now giving attention to the synovium and the synovitis that we've reviewed. We're looking at cartilage degradation and products thereof that are in the milieu of inflammatory mediators within the joint fluid, giving special attention to macrophages and the pro-inflammatory mediators that we've superficially identified therein with interleukins, TNF, and so forth. What is different is that we're addressing these now with a radiotherapeutic radionuclide. And to give you the crash course here in radiotherapeutics, we would have an element which is energized by some means, and then that gives rise to a number of subsequent changes. One might be the release of high energy electron, beta radiation. Another might be 2 protons and 2 neutrons escaping that nucleus. That would be defined as an alpha radiation particle. We also might have release of high energy electromagnetic photons. That would be gamma radiation. But our focus here is that releasing from the circular orbit of convergent electrons. And specifically, this is with the radiotherapeutic 10-117M. Now, 10-117M and technetium-99M are both gamma-emitting diagnostic radionuclides, and post-treatment scintigraphy can confirm location of injected material and is one way that gamma radiation can assist us in giving some idea if, in fact, we're reaching the target structures. This is achieved by implementing the treatment of radiosynoviorthesis with the therapeutic 10-117M. The M referring to metastable as it relates to the rate of decay compared with other radionuclides. Radio refers to the radionuclide, synovi refers to the synovium target, and orthesis refers to a restoration back to a more normal state. Summarizing major points, 10-117M emits discrete low-energy convergent electrons in its mode of action. 10-117M penetrates the synovial membrane. Pro-inflammatory macrophages phagocytize the 10-117 colloid particles, causing a non-inflammatory apoptosis. And this macrophage apoptosis renders the inclusive pro-inflammatory cytokines and chemokines to be ineffective. The synovitis is abated, and the stimuli for pain are diminished. Histologically, there's an effective return of the synovia to a more normal state. And ultimately, the 10-117M decays to inert 10 and is cleared by the lymphatics.
Chronic osteoarthritis, or OA, is one of the most significant debilitating conditions in companion animal health, afflicting up to 20 million dogs in the U.S. Current treatment options can cause systemic side effects, are short-acting, or only target pain receptors, and thus may not fully address this disease that creates such discomfort for the dog. Inside the OA diseased joint, a vicious cycle of inflammation causes the synovial membrane to swell and the cartilage to deteriorate. The overproduction of inflammatory macrophages and synoviocytes creates ongoing progressive inflammation and pain. Synovitin OA provides long-lasting pain and inflammation relief by the dual targeting of these underlying drivers of joint disease. Synovitin OA is a veterinary device consisting of microparticles of the novel radionuclide 10-117M. These particles are suspended in a colloid, which is injected into the joint to safely and effectively treat synovitis for up to 1 year. The appropriately sized 10-117M microparticles stay in the joint and emit low-energy conversion electrons with only a 0.3 millimeter range of activity. This provides targeted, precise, non-systemic therapy with no clinically significant local or systemic side effects. Inflammatory macrophages and synoviocytes selectively engulf the synovitin OA microparticles and are subsequently deactivated by the conversion electron energy. The microparticles remain active and are engulfed again by nearby synoviocytes and macrophages for sustained action against inflammation. Synovitin OA microparticles decay to harmless, inert tin, but its clinical effects last up to a year with just one injection, providing durable pain and inflammation relief and helping to restore active living.
Many of us are not familiar with the term apoptosis. However, it's worth noting that the process of apoptosis, which I like to think of as somewhat akin to putting a hand grenade into a macrophage, it actually is the destruction of this macrophage and the ablation of the inflammatory mediators therein that are in their pro-inflammatory state. But note that it is a non-inflammatory process. And this is different than necrosis, which actually is an inflammatory process. In contrast to contemporary therapeutic approaches to osteoarthritis, or as a multimodal component of a treatment protocol as an adjunct, there are a number of advantages worth noting with radiosynoviorthesis with 10-117M. Principal to which are that indeed there's an extended therapeutic benefit, oftentimes at least or in excess of 1 year's duration. And of course, the focus of this technique of treatment is that it breaks that inflammatory cycle that we were introduced early in this tutorial. It also can be used complementary to multimodal procedures and therapies, so we don't need to worry about any contraindications with other therapeutic approaches. It avoids the NSAID and corticosteroid side effects that we have seen over the years and make us very cautious with the application of those modalities. Also, there's no compliance issues for pet owners in medical dosing. So unlike SID or BID per os treatments associated with the management of osteoarthritis, this is a one-time intra-articular administration of a radiotherapeutic that is good for 1 year. Also, for the practices, it can be a practice builder. At the end of the day, of course, as professional veterinary attendees, we are interested in the technical aspects of radiosynoviorthesis with 10-117M. But at the end of the day, the pet owner simply wants to see that their dogs are pain-free and happy. In summary, osteoarthritis is indeed a total joint disease, not simply a disease of cartilage. Synovitis is present in osteoarthritis from the earliest signs, and it precedes radiographic osteoarthritis. So the earlier we can administer treatment, likely the better. Cartilage destruction is driven by activated macrophages and their inflammatory mediators. And the macrophages, which in essence are packets of pain activators, present a new target for therapeutic intervention. 10-117M, a novel convergent electron-emitting radiotherapeutic, provides targeted activity against pro-inflammatory macrophages. Thank you for your attention and have a good day.